Welcome to the Public Health Webinar, HTI 1 Proposed Rule. My name is Larnie Reyes with Kaufman and Associates. I will be assisting with the logistical support for this Zoom session. To ask questions, click the chat button at the bottom of your screen. However, please note that there are restrictions to what questions that can be answered due to the Administrative Procedure Act. Additionally, we ask that you select the speaker view option located at the top right side of your Zoom interface. This will allow you to see the speaker as they present or share information. Finally, please be aware that today's session is being recorded. Closed captioning is available by clicking the CC icon at the bottom of your screen. I will now turn you over to Sanjeev Tandon.
Good afternoon, everyone. This is Sanjeev Tandon from CDC, and I'm joined with in this webinar as a co-host by Rachel Abbey from ONC. Today, we have two excellent presenters on this topic, my federal colleagues from the Office of the National Coordinator for Health Information Technology, Elizabeth Myers from the Office of Policy, and Jeffrey Smith from the Office of Technology. So during this webinar, as mentioned, there are certain limitations because the proposed rule is in the public comment period until June 20th, 2023. So our presenters will be limited in terms of what questions they can answer or not. I'll hand over the floor to Elizabeth Myers. Thank you.
Hi, thank you. Sorry, too many mute buttons. Hi, my name is Elizabeth Myers. As mentioned, I am the Deputy Director of the Office of Policy at ONC, and we want to thank our colleagues at CDC for co-hosting this discussion with us. We are very, very excited at the publication of our proposed rule, or notice of proposed rulemaking, which has a new term, which we're going to talk about in just a second in terms of the naming convention. So we're really pleased that you can all come and join us and have this sort of public health centric version of this discussion about what is in the proposed rule and why we proposed what we proposed. Again, I will reiterate the caveat that has already happened. As we get through it to any questions and answer period or questions in the chat, there is just an ask that I have of you all to be respectful and understanding if we say that we can't answer something. The Administrative Procedure Act, as previously mentioned, governs how we approach rulemaking, including how we have to preserve the integrity of the rulemaking process. And that does mean that we can't, with any entity, give information during a rulemaking cycle beyond what has been proposed. So that is why we try to be very thorough in the proposed rule. We ask a lot of questions in the proposed rule. We try and put in detail about the types of standards that we're thinking about, so that it gives people as much information as we can to try and give us constructive and useful feedback, and we preserve the integrity of ensuring that everyone has equal opportunity to hear and address the same information. So let's proceed. And you'll see more disclaimers, basically the same things I just said. For everyone's awareness. But the other thing to add is that we have made every effort as possible to make sure that the content in this particular presentation, including the slide deck and the notes that we speak from, are as accurate as possible. But again, the rule itself is the source of truth. So please trust but verify and ensure that you're taking a look at the actual content of the rule if you intend to see what the proposals are and comment on them. We do appreciate that you would look at that directly and take a look at what's in there. So you're commenting on the actual specifics that are part of the rule. And then again, as mentioned, we have to preserve the rulemaking process, so we can't interpret further or provide any clarifying guidance beyond the language that is included in the rule. Let's move on. Okay, so we're going to answer the three whats that we think that you would want to know. And these are what's in the name, what's in the rule, and what does this mean? So let's move on to the next slide. So what's in the name? I realize this is a little bit wonky and seems like a sort of strange thing to be talking about when we talk about public health and our proposals, but we've done a name change and there's a very, very good reason for it. And so we did want to share that with people so they're fully aware of what's going on. Previously, we approached our regulation and our certification program as additions. So we would put out a rule for whatever addition of technology there was. And you can think of that as sort of like a licensing package of a suite of things that could be certified in our program. As the world has evolved and our engagements with our federal partners have further evolved, that has stopped making as much sense. In a lot of different ways, there is a need to be thinking about standards and thinking about functionalities and thinking about more rapid responses to changes in emerging technology or things like we've recently dealt with, changes like the pandemic that caused a lot of different types of data needs and different types of interactions that needed to be addressed very quickly. And it's hard to respond to that when we continue to do rulemakings that are on that type of cyclic basis to do a full edition every 5-ish years. So for that reason, we've done two things. I'm going to start with this one and we'll go to the next one in just a second. One of them is that we aren't that we're actually changing the way we name our regulations to coincide with this very specific and deliberate shift in how we think about our regulatory space to make sure that we're being clear and consistent, that our regulations are cyclic, they are transparently iterative, meaning that each one builds upon the prior one, and we're trying to advance things in that particular way, but also to make a clearer naming convention so that people can understand them as sort of versions of standards in the same way that we approach those types of things. So with that in mind, we are putting health data technology and interoperability at the forefront. And then from there on, you'll see the specifics that individual rule might be going forward, but that naming convention of health data technology and interoperability will remain consistent for all of the rules. And then they'll be numbered, so it's really easy to tell sort of which iteration things are as we're going forward and thinking about how we do more rapid cycle regulations that can address some of these changes that need to happen in closer to real time. Next slide. So we'll circle back to the name thing in just a second, because there's more to that I think is really important. Even though it's not specific to public health, it's important for you all to understand because it relates to how the work that you do can be reflected and supported by standards and technology as we think through this shift in how we approach our regulatory space to support the broader scope of what HHS needs and less about just those CMS programs that were the historic start. So what's in this rule is a new regulatory approach for certification criteria. So not only are we changing the name of the rule, but we're also removing that construct of additions so that we can deal with individual functions and individual standards needs in closer to rapid time, rather than doing whole cloth or rip and replace additions that caused sort of the whole country to have to update all at once, and that also caused our partners to have to wait for an addition to come forward if there were new functions or things that needed to be added. This lets us be a little more flexible, so we're going to talk a little bit more about that. There are also certification standards and functionality updates. We also have a proposal that talks about decision support interventions and algorithmic transparency. One of my colleagues will talk about that. We have our insights condition and maintenance of certification requirements. That's new. For those who have been following the CARES Act and the implementation over the past 5 years of the provisions in that rule, you'll note that that is the EHR reporting program within that within the CARES Act requirements for ONC. So we'll talk a little bit about what that is and what it looks like. There are some information blocking updates. Again, these are things that will be relevant for you to be aware of. They may not all be applicable for a public health use case, but they're things that are important for you to keep in mind. And then there are several opportunities for comment, including some specific requests for information that are relevant for public health that we think that you all should be aware of, and we'd love for you all to take a look at and share with your constituencies as well to ensure that they're taking a look and engaging in this process and providing us feedback. Let's move on. So today's webinar, we're going to zero in a little bit from the overall content. We're going to talk about some of the things I mentioned very briefly, and then I'll be passing it off to my colleague to talk a little bit more about the specific proposals for immunization, electronic lab reporting, and cancer case standards updates. We're also going to talk about the US CDI and the version that exists, give you an update of where that's going and what version 3, which we've proposed to adopt in this rule. We'll talk a little bit about electronic case reporting, and then I'll take the microphone back and talk a little bit about that insights condition that I mentioned. That's the quote unquote EHR reporting program that was in the 21st Century Cures Act, as well as information blocking and some of the requests for information. So we've got a lot of stuff to get through. So I apologize if I'm talking too fast. I'm going to try and keep it clear as possible, but let's move on and actually dig into the substance. So the why we are doing this, this is not necessarily a regulation that was specifically and explicitly required by statute in the manner that some of our previous ones were, with the exception of the EHR reporting program. And the overall inclusion in the 21st Century Cures Act of requirements for application programming interfaces that can be used without special effort. So those particular pieces of that statute, this rule continues to move them forward. But there have also been executive orders that have come out that are specific and relevant to emerging issues and emerging healthcare concerns. This rule is attempting to also help us address some of those, and that obviously includes the COVID-19 pandemic and the executive orders relating to data-driven responses, ensuring that we have readiness for future high-consequence threats, and making sure that we're supporting the data needs that the rest of HHS might need to implement their parts of that executive order. And then the executive order, which is addressing advancing racial equity and thinking about what are the data standards and what are the data conformance methods that we can include within our program that would support and advance the use of data that can help to identify, address, and prevent negative outcomes and harm, but also resulting from discrimination, but also specifically address individual challenges related to health equity and health disparities. So that's sort of the driving functions from a regulatory and statutory point of view, as well as an executive orders point of view. So those are the pieces that we're trying to address and think through. And then from a very high level point of view, these are all foundational principles that relate to our fundamental purpose for existing, which is to try and advance interoperability, ensure that we're meeting the requirements under our actual authorizing statute, the HITECH Act, to think about the entire scope of items within there that range from public health to cost to quality to access, to ensure that we're meeting the needs of a nationwide health IT infrastructure. So let's move on. So I'm going to talk very briefly about this. Again, I don't want to spend too much time on the things that aren't as related to public health, but this is actually something that's important for you all to keep in mind and consider, because it does have an impact on our ability to work together to move individual use cases or individual needs in a different way than what we previously did. Next slide. So previously, as we know, we had editions. We had the 2011 edition, 2014 edition, 2015 edition. We did some updates to the 2015 edition in our last rulemaking. And what that did was require this whole scope of an entire package of certification criteria to be redone each time there was a new edition. And that meant that we sort of waited on things to put them into that edition, and or we had a little bit of a push-pull because we were trying to have the entire country sort of updating that edition all at once in relation to the programs that CMS runs through Medicare for the EHR incentive programs, which are now called Promoting Interoperability. The change to move away from that allows us to think about things in a slightly different way. We think that it will allow us to more effectively use new standards and new functionality on an individualized basis, meaning some standards may be further along the readiness cycle than others. And when we were wedded to a wholesale edition, we couldn't consider that variance in the same way, whereas we might be able to look at an individual health IT module that is specific to a specific standard or function and move that on a faster path than if we're trying to do an entire redesign of the entire edition of the program. It also allows the users of health IT to work with their health IT developers to update systems in a more hopefully user-friendly and efficient manner. The prior state of affairs was that everybody was updating all at the same time within a single year, the entire country, which left a lot of people out and caused a lot of consternation and issues with people having to do that wholesale update at the same time that everybody else is, and really trying to figure out if that was really the best pathway. There's a lot of burden on health IT developers as well, ensuring that they're being prepared and able to make that type of full sweeping product change, but also on providers who are trying to figure out and understand what they're supposed to be using when. Doing things this way would mean that there's always sort of one version of certification criteria that are relevant at that point in time. When someone is looking to participate in a program and there's a new measure, that new measure would be introduced at the same time as the functionality that would be able to support it. And that's how we work closely with CDC or CMS or others that are looking at those measures or requirements to make sure that they're met. And that way providers can really use what they need to use to do the program that they're participating in, but also know that what they have is going to support them, because there isn't going to be this confusing sort of addition construct. It's sort of, if it's certified, it's relevant, and then we put some responsibility on the developers to keep those standards updated over time. And we'll talk about that in the next slide. So how are we establishing the applicability of certification criteria if we don't have additions, right? So everything I just said sounds great, but how is it actually going to work in real time? So what we're doing, instead of having additions that transfer the entire product or the entire suite of criteria, when we think about updating an individual criterion with the exact standard that needs to be updated and or the function, we're actually going to put the dates for that criterion into it itself. And that will mean that it has a transition period, which is often necessary, where you can use two versions of the standard until it's actually fully baked and ready to go. But then we'll have an expiration date whereby that prior standard would no longer be applicable. So a criterion would have to be updated and rolled out to customers. So in other words, provided to customers in order for that certification to be maintained over time. We're doing this in two ways. If we go to the next slide, there is a change in the criterion itself, which allows for us to have a conformance mechanism that says for a product to maintain certification, it has to be conformant with that standard, and the dates for each individual criterion let us know when that standard is expired and when that new standard is the only version that's allowable. But then we're also thinking about this from a transparency point of view. What does it mean for customers to know that from a behavioral point of view, a transparency point of view, that their developer has made the steps to do this, because we know developers really care about making sure that their customers know this as well. So it's a push-pull there that allows developers to really say, not only is the product technically in compliance, but I am attesting to the assurances under the certification and conditions, the conditions of maintenance conditions for certification. Sorry, I'm getting that boggled. The conditions and maintenance requirements. So these are the behavioral aspects and transparency requirements that developers need to do in addition to the technical conformance to the test. So we've included both ways, that it's both technically conformant, but also developers are making an assurance statement that they are doing these updates timely and that they are providing them to customers. And hopefully this should provide both transparency to customers, but also the assurance itself that the product that you're using at any given time has the most relevant standard and is moving towards updates that may be necessary for your program participation. So let's move on. I'm going to pass it off to my colleague to talk through the certification standards and requirements, Jeff Smith, who is on the line with us. But before I do, I want to reiterate, I know those things that we just went through aren't necessarily specific to public health, but again, we think that they will have a positive impact on our ability to work together as a health IT and public health community to advance the standards that we need, to ensure that we're being more responsive to changing data and functionality needs, and to ensure that those are rolling out to users in a timely and effective and transparent manner. So while they are sort of big, administrative, probably boring sounding things, we actually think that they're really useful and relevant for us to be able to specifically meet the types of needs and challenges that we've been talking about with the public health community. And with that, I will pass off to Jeff.
All right. Yeah, thanks, Beth. And yeah, just to highlight what you just said and potentially frame it just slightly differently, I think one of the underlying reasons that we're proposing those kinds of programmatic updates is so that we can ensure that regulation doesn't get in the way of updating standards and get in the way of having a facile and flexible certification program. So at any rate, I'm going to talk here about some certification criteria and some standards that we are proposing to update. So if you can go to the next slide, please. So I'm going to start with this is kind of an overview of the standards that we're looking to update. And I know this probably looks like a foreign language to some of you, but this is the nomenclature that we live in. So I think at a really high level, it's important to note that we are proposing to require health IT developers to adopt and use in their products the newest version, well, the version 3 of the US CDI. And we are proposing to adopt a new baseline for minimum standards code set. And I'll talk a little bit more about what that means. And then there are a host of new and revised criteria that we are proposing. Most relevant for this group is probably electronic case reporting, and I've got a lot of information on that. But we're also looking to make some updates to the standardized API for patient and population level services, as well as a new criterion on patient-requested restrictions of their information. I will note here a nice example of a quirk that we have to work through as a result of having a program that is in regulation. And that is that in the preamble, we have proposed to adopt the CCDA Companion Guide Release 3, as well as the US Core Implementation Guide 5. Even though we know that US Core Implementation Guide 6 and Release 4 of the CCDA guide are actually better fits for purpose in terms of supporting US CDI version 3. Because of the way the Administrative Procedures Act works and conversations that we had with our Office of General Counsel, we had to propose the version that was out and available for review and not necessarily the versions that we know are going to better support US CDI version 3. However, we do say that based on the annual cycle, we believe that US Core version 6 and the CCDA Companion Guide Release 4 will be published before we issue a final rule, and it is our intent to consider adopting those IGs to support US CDI v3. Next slide, please. Okay, here are some vocabulary standards that we're proposing to update and how they impact the public health criteria. You'll see that we're adopting new baselines, and again, these are referred to as minimum standard code sets. And I think I've got a slide later in this deck where we'll talk just a little bit more about what that means. Essentially, I'll spend more time on that slide when we get to it. So next slide, please. Okay, so hopefully all of you are familiar with the US Core Data for Interoperability. This is currently the law of the land. Health IT developers, in order to be certified by our program, have to have updated their technology to version 1. And as you can see there on the right there, version 1 has some 50 some odd data elements, and this does represent the minimum data set required for interoperability. And this means that one system is capable of handling these data elements from another system, and that those data elements are consistently represented using specific standards. We, of course, have gone through a few cycles of our standards version advancement process, wherein we have adopted new versions of US CDI, both V2 and V3 have been adopted officially. I think we've demonstrated how this works, and I think this NPRM demonstrates another step in that process, which is raising the floor. So our intent here is to adopt US CDI versions, to advance them, make them available for use in the program through the standards version advancement process, and then raise that floor over time and do it transparently so that industry has some sense of where we're going. So I think if you're paying attention, the fact that we proposed US CDI v3 in this NPRM should not have been a surprise whatsoever. All right, next slide, please. Okay, here's a snapshot of what's in US CDI v3. I realize that the font is very small, but you can go to the ONC website and learn everything you could possibly want to learn about US CDI v3. I can say here, we've obviously got a number of new elements from v2 Those new elements are clustered around the notion of health insurance and health status, as well as some new lab and medication data elements. Next slide, please. Okay, so here's where we go into a little bit more depth on US CDI v3. We do propose that Health IT modules would have until December 31st to update their technology, December 31st, 2024, to update their technology to v3. So that's an important date to mark on your calendars if we finalize as such. And I think the benefits here are hopefully well understood and hopefully well supported, and that is to have data be consistent across space and time. Here are the specifics on the certification criteria that would be impacted by this. I think we can go to the next slide. Okay, so I warned you about the slide on minimum standards code set, so here it is. I think what's important to note is that we're moving the baseline. Several of these standards are listed in regulation, including SNOMED, LOINC, NDC, RX norm, et cetera. Those citations in the current Code of Federal Regulations actually reference standards from like 2014 and 2015 and maybe 2018. And we are proposing to just raise the minimum bar to the last version of those standards that published before we got the notice of proposed rulemaking out into the world. I think it's important to note that these minimum standard code sets do update frequently. And so we would expect Health IT developers to use more recent baseline or use more newer versions of these baseline criteria. And are hopefully, these are things that we'll periodically raise the floor to. But generally speaking, we've heard feedback from industry, and generally speaking, when there's a new SNOMED or LOINC version that comes out, developers are usually updating to those newer versions on a fairly regular and consistent basis. But this would raise that minimum to say you'd have to use at least those versions. Okay. This concept will come back around when we talk about electronic case reporting and the reportable conditions trigger code value set. So keep that in mind. Next slide, please. Okay, so on the subject of electronic case reporting, next slide. We've got a number of slides to cover this topic because it's pretty in-depth and pretty central, I think, to the work that many of you do. So our proposal is to require that Health IT developers support electronic case reporting using consensus-based industry-developed HL7 CDA and or FHIR standards. This is consistent with the way that the certification program has run historically. Electronic case reporting is, I think, one of the last or remaining criteria that don't reference a standard, or at least one of the more major criteria that don't reference a standard of any kind. And that's because back in 2015, when this was getting put into the program, or in 2014, 2015, there weren't standards that we could point to. In the intervening time, most notably more recently, in the intervening last couple of years, really, there has been the development of both CDA and FHIR implementation guides for the electronic initial case report, as well as the reportability response. And there's a FHIR profile for the electronic reporting and surveillance distribution, or ERSD, function of the electronic case reporting. We also propose that developers of certified Health IT may certify to these revised standards and functionality 60 days after the effective date, but they would have until January 1st, 2025 to update their technology. So the way that we constructed this is allowing developers the option to certify using these standards right away, as soon as the rule is effective, basically. But we gave them a deadline of January 1st, 2025 to update their technology and provide that technology to their customers. All right, next slide, please. So the benefits are hopefully well understood with this group, but we think that standards-based electronic case reporting will facilitate transmission of electronic case reports to public health authorities. It'll improve interoperability and implementation consistency. It will hopefully empower public health authorities to have an improved picture of where and when disease outbreaks occur. We think that these will improve bidirectional exchange between healthcare providers and public health authorities, as well as promote the sharing of standardized knowledge artifacts related to electronic case reporting. And last, but certainly not least, since we're naming standards in the actual criterion, we would be able to use the standards version advancement process as new standards became available. So if there's a new version of these fire profiles that come out, or a new version of the implementation guide, we would be able to run that through our standards version advancement process. And presuming that the standard is a good standard, a better standard, does more things, we would hope that developers would certify to that new standard through SVAP. And then if not, over time, we could consider raising that floor through the regulatory text as well. Okay, next slide, please. Okay, so I'm going to start with an overview of the fire-based approach that we are proposing, and then we'll turn to the CDA-based approach. So on the on the fire side, as I mentioned, there's 3 profiles: the EICR, the RR, and the ERSD profiles. And we would require a health IT module to support all of the aspects of the first 2 profiles, and then we have identified specific pieces of the ERSD profile that we would like health IT developers to support, and those are the specification and supplemental library that's listed in the ERSD. We also would require a health IT developer who chose the fire-based approach to support the reportable conditions trigger code value set. We had to name a specific version of that in the Federal Register, and that version was the March 29, 2022 version. We of course know that there are newer versions of that, and there will be newer versions of that. And so we were able to frame the RCTC value set as really a collection of terminologies and actually consider it a minimum standard code set. So the expectation here is that when new versions of this come out, developers would would use the newer version of the RCTC. Next slide, please. Okay, so here's an overview of the CDA-based approach. It's very similar, but we're pointing to CDA rather than fire standards for the EICR and the RR reportability response. As it relates to the ERSD, the CDA implementation guide actually includes the fire profile as part of that, and the standard itself says that health IT modules should be able to use the ERSD profile, even if they're implementing the CDA using the CDA implementation guide. So that's something that we do ask for comment on and ask for questions on. And again, I've got similar information around the RCTC value set, which I think we go into more on the next slide. So next slide, please. Okay, so here is the deep dive on the RCTC value set. So it's really kind of a collection of different standards: SNOMED, LOINC, RX norm, CVX, and CPT. And we were able to kind of, again, given that the contents of the RCTC value set update frequently, we recognize the RCTC value set as a minimum standard code set that enables ONC, which enables us to reference a persistent version of the RCTC value set as a baseline. But developers are able to support newer or updated versions of the RCTC value set for their customers as soon as a new release is available. And I'll just kind of highlight here that health IT modules may voluntarily support updated versions of the RCTC value set. We anticipate that developers would be incentivized by their customers to take advantage of this opportunity to voluntarily support updated versions, but certainly are interested in feedback on experience to date and whether developers do adopt newer versions of the RCTC value set, as well as other minimum standard code sets. It would be important for us to hear on whether those standards do get updated, or if those versions newer versions do get used. Okay, next slide, please. Okay, so here's really at a high level, the pieces of the reg text that we have translated here into one slide. A health IT module that's going to be certified to the kind of newer version of electronic case reporting must be able to consume and process electronic case reporting trigger codes and parameters and identify a reportable patient visit or encounter based on a match from the RCTC value set received from the ERSD profiles as specified in the HL7 Fire ECRI implementation guide. A health IT module must be able to then create a case report consistent with at least one of the following standards, and that is the Fire standard or the CDA standard. And then a health IT module must be able to receive, consume, and process a case report response that is formatted to either the RR profile of the HL7 Fire IG or the HL7 CDA reportability response implementation guide. And then last but not least, the module must be able to transmit a case report electronically to a system capable of receiving an electronic case report. So next slide, please. Okay, so I'll just highlight a couple of things here. We are proposing that the functional requirements for health IT modules certifying to F5 remain agnostic as to which reporting platform the electronic case is transmitted. That's why we don't reference a specific standard or reference a specific endpoint, I guess, or receiving entity. Rather, we propose to require that health IT modules be capable of transmitting case reports consistently with the reporting requirements established by the PHA. And I will note here that I think some of the feedback that we received during the HITAC task force was around the whether or not we were requiring case reports to be sent electronically as part of this conversation around us not being specific on where it gets sent. And I think it's important to note that we are very much requiring health IT modules to send case reports in a standardized format, and that format needs to be consistent with the CDA or with Fire. But I know that was a point of some confusion, and if you've got further comments on how we can clarify that, happy to receive those as well. We do note that a health IT module certified to F5 may meet the reporting requirements by supporting case reporting to any system designated by the public health authority and capable of receiving an electronic case report. This could be a state-based registry, it could be a health information exchange, or it could be an intermediary or proprietary platform, such as APHL's AIMS platform. We do seek feedback on a number of dimensions. The first is really the option to use either CDA or Fire or both. Our understanding was that the industry had not necessarily coalesced around either or. So we have this at least construction in our regulation text. So that means that it could be one or the other, or it could be both if a developer wanted to certify their technology to both for some reason. We do ask questions about whether or not the ERSD profile is appropriate for health IT modules that are certified to using the CDA IGs, as the CDA implementation guide itself states. And then we ask whether the ERSD profiles are adequately scoped and defined to establish baseline functionality. So for those of you intimately familiar with case reporting, take a close look at the Fire standard and the CDA standards. Let us know what you think about those, and certainly happy to and eager to receive feedback on those fronts. Next slide, please. Okay, so last slide here on F5 is on the deadline for transitioning. As I mentioned, developers would have until midnight, December 31st, 2024, to update and provide their health IT modules certified to the proposed revised standards and functionality for F5. And we note there in the proposal that developers would have to do well, basically has that deadline. We have to phrase it somewhat oddly given our regulatory constructs, but that's the takeaway there. Developers who are ready to certify to using the CDA or FHIR approaches may do so pretty much as soon as the rule is finalized. And then they'll have until January 1st to update their modules to the new standards-based approach to electronic case reporting. Okay, I think that's the last slide for F5, so please, next slide. All right, let's see here. Beth, you want to take it here or you want me to take it? How about I'll take these slides and you can do the information blocking slides.
Got it. Sounds good.
Okay, cool. All right, so you get to hear my voice rattle on for another five or six slides here. The insights condition and maintenance of certification requirements. Next slide, please. Okay, so this is, I think this is relevant to the public health community for a number of reasons. Most notably, we have a couple of public health facing measures, but what does that mean exactly? So as part of the 21st Century Cures Act, Congress included a pretty weighty provision called the EHR reporting program. And this is how we are translating the bill, the 21st Century Cures Act into regulation. We're including it, and I think ONC has telegraphed this for a number of years, actually, that we would include it as part of the conditions and maintenance of certification requirements for health IT developers. And we've been on this journey to develop this program and put it through regulation, through comment and through comment period, notice and comment for a number of months, if not years, really. So the Cures Act actually laid out several dimensions that they wanted reporting criteria to cover. Those included interoperability, privacy and security, usability and user-centered design, and then conformance to certification testing. Rather than come out of the chute with criteria spanning all of those, we decided to focus first on interoperability. And so the measures that we have developed, the reporting criteria, are really different dimensions of interoperability that we are looking to get insights on, hence the name Insights Condition. Essentially, what we're trying to do here is address information gaps in the health IT marketplace, as well as provide insights on the use of specific certified health IT functionalities, namely those that have key interoperability components. As well as we are looking to get information about customers' experience with certified health IT. Next slide, please. So we worked pretty closely with the Urban Institute, who developed a set of draft measures and those measures were based on research, including market research, as well as input from a whole bunch of stakeholders, maybe some of which are on the line today, and with health IT measurement experts, and with input from feasibility and validity testing. So I think it's important to note, again, part of the framing of this EHR reporting program as an insights condition is that we're looking to get insights. We're not necessarily looking to compare developers one to another. Developing measures on EHR performance is incredibly complicated. And so when we think about how this program would be operationalized, we did have to design measures that would be reportable for developers across, really their entire client base. And so the measures that we came up with do really try and focus on answering some pretty important questions about the state of interoperability in our country. The measures themselves were examined by the HITAC and a task force that was dedicated to the measures that Urban drafted. And then we ourselves took the Urban measures and really modified those slightly, really to fit within the constructs of our program. So there's been a lot of public input on these measures up to and including the release of this NPRM. Next slide. Okay, we don't have time to go into all of these, but I think it's important here to note that there are really 4 buckets of interoperability that we're trying to get insights on. That covers individual access, clinical care information exchange, public health information exchange, and then standards adoption and conformance. I'll note that the ONC website dedicated to the NPRM includes measure specifications. And those specifications are actually several pages long that really get into the details of each and every one of these criteria, or sorry, of these measures. I'll note for purposes of this call and this audience, the public health information exchange measures do focus on immunization. We've got 2 measures there, one for immunization administration, submission through Certified Health IT, as well as immunization history and forecast access through Certified Health IT. So if you're interested in those pieces, I highly encourage you to look at the measure specifications because they do go into some detail on how we're looking to have developers report those pieces. And again, I will say it's really the intention of the program to have developers report across their client base. There are, of course, considerations and caveats, mostly related to those developers that have so few clients that reporting on a measure might actually reveal who the client is for some reason, which could have other deleterious effects. We don't want that. So we do have some very small caveats for some developers and some measures. We're not looking to divulge more than is appropriate. But I do think that when you start to consider the scope of this, we could actually get some really very interesting insights on the state of interoperability if we were able to get if we were able to get a picture of how developers' technology is being used at the national level across all of their deployments. Okay, next slide and last slide, I think, for me. We did implement this program consistent with the statute, which did require that we not unduly burden small and startup developers. And so we essentially set thresholds that said, if you're a developer with technology certified to a specific criterion that is part of this program, you have more than 50 hospital users or 500 clinician users across the certified products that you offer as a developer, then you need to participate in this program, which means if you're a small developer that doesn't have that many hospital or clinician users, then you can avoid participating in this program. Last but not least, we are going to have developers submit data through a web-based form and method consistent with the requirements of the CARES Act, and we will make data publicly available via our website eventually. Next slide. I lied. I thought that was the last slide. Here we go. This is the last slide. Okay, so we are looking to have developers submit data every 6 months. This would be April 1st and October 1st. This maps nicely to the dates and number of times that a developer has to comply with attestation requirements. So we decided to try and gain some synergies there. We think that having information provided every 6 months and phased in over the course of 2 years will help us have an accurate and up-to-date picture of interoperability. I think it makes more sense, probably you all get it, to get data more frequently. And that way we can just have a more dynamic view of what's going on out there. And year 1 measures versus year 2 measures, I think you can see year 1, we would have both public health information exchange measures. We're proposing to have both of those be reported on in year 1, and as well as the individual access. And then one of the standards adoption and conformance measures, the one on applications supported through Certified Health IT, that measure would be reported in year 1. And then the other clinical care information exchange and standard adoption measures would be reported in year 2. Next slide, please. Okay, Beth, it's back to you.
All right. Thanks for taking insights. I was wrapping up a bunch of responses to comments in the chat. Please do keep them coming. We will do our best to get to as many questions as we possibly can and appreciate the really good dialogue that is going on. So let's move on to information blocking. Again, my sections tend to be things that are for your informational purposes, whereas Jeff's is the meat of things that you probably want to take a closer look at. Make sure you're reading, and you'll note in the comments, if you read the chat, that there are several places where I've said, please comment on that, because they're really good points that we need to take into consideration and understand how you see these things and what you think we should do or not do, including at the very nitty-gritty level of within an IG, there's a must that should be a may or a may that should be a must. We need to hear that. We can't opine on it right now, but we can take your comments and take a closer look at them and determine if those are things we should consider for the final rule. So that's my shameless plug on the chat. Let's move on to information blocking. We only have a few minutes left. So what we've done in this rule is not reestablish major changes to information blocking. What we're doing is further scoping the definitions of what we finalized in the 2020 final rule implementing the provisions of information blocking under the CARES Act. So we've updated a couple of definitions, and we have modified the exceptions. So this is important. There are not new exceptions. Instead, we have taken a look at the existing exceptions and modified certain conditions within them based on basically the public input that we've had, as well as what we've been seeing in the sort of cycle of complaint processes that OIG has been working through to come to an understanding of what might provide some more clarity and what might provide some more supports and assurances for the actors involved in information blocking, that they're able to comply, but also that they're ensuring that they are in fact sharing information as the default. And then finally, we've included a couple of requests for information that take a look at things that are focused on if we are going to continue evolving things in the future, what should that look like, but also the interplay between information blocking policy requirements, which is really important to remember that information blocking isn't constrained to certified health IT users. Information blocking applies broadly to all of the actors, which could be healthcare providers. It's a really sweeping set of healthcare providers. It includes labs, it includes pharmacy. They are all expected to be defaulting to information sharing unless one of the exceptions is met. And it also doesn't apply exclusively to the use of the specific standards that we include in our program. So those are just really important things to keep in mind. But in those RFIs, we ask specific questions about what we could be doing in our program that might make it easier, that might make additional actors more easily able to address their unique needs. For example, the actor community is, again, broader than who has been participating in the promoting interoperability programs. It does include things like labs and pharmacies and a wide range of healthcare providers, as well as networks and health information exchange organizations. So keeping that in mind, we've asked some questions on like, what could we be doing differently? Sure, are there additional technical capabilities that might help to support things? So let's move to the next slide. So the offer health IT definition, this is an important piece of the definition that we're updating here based on feedback. What we, and some of this in the information blocking section is going to be a little bit nitty gritty to those information blocking provisions. So if you feel like I'm speaking over your head, I do apologize, and just let me know, raise your hand and ask a question when we get to that point, put it in the chat. Because this is all sort of policy constructs that were in our rule, in our last rule. And so if you're not as familiar with those, some of this is just going to take a minute to wrap your head around. So in our first rule, we talked about offers of health IT and how that worked from the regulations point of view in what category they fall into as an actor. So what we've done is to further clarify that so that you can understand that the role that an entity is playing when they are not sharing information and what the information request is about is what determines how the enforcement of that might look. So in other words, if you're acting as a developer versus a provider, if you're a clinical setting that has your own homegrown system, there's some differences there in what you're supposed to know and what you're supposed to be able to do. So that's what we've done a little bit of changes here. The proposal is to generally include this construct that you can actually see right on your screen, providing, supplying, or otherwise making available certified health IT under any arrangement or terms except for certain beneficial or necessary activities that will be excluded. And those exclusions are all carefully defined and aligned with other statutory provisions like Sarkin anti-kickback to ensure that we're not at cross purposes with some of those provisions. We explicitly codify that we do not interpret individuals or other entities to offer health IT when they engage in activities such as donations and or subsidized supply agreements. So this could be lots of different types of entities that do this. We know this is out there. I don't know for sure if there are public health agencies that this actually applies to or not, but it's just something to keep in mind. There are sometimes healthcare entities, sometimes nonprofit entities that are supporting the other entities in getting technology in order to make sure that they can connect and can participate in things like an alternate payment model or care coordination pilot or project that is looking at a state demo or a waiver program. So that's really what this is talking about, is trying to differentiate when it applies and when it doesn't to ensure that we're not inadvertently creating a perverse disincentive to engage in those types of activities that are helping to advance health IT and health IT networks that are actually interoperable. So we believe that this gives some better clarity for folks and understanding that if they're engaged in some of these complex relationships where maybe health IT supports are shared, or maybe they're offering a system to someone, or maybe they're licensing tech, so that it's a little more clear when it falls into the bucket of being a certified health IT developer and when it doesn't. And we hope that that will help to sort of settle some of those concerns that had happened, that people were concerned about entering into those types of agreements if they might have a negative impact. Let's move to the next slide. So the infeasibility exception, we modified and did the uncontrollable events condition. So this is, again, very nitty gritty on the legal speak and policy end, but this is just for your all awareness because, again, if there is something that is impacting your community, some of the public health entities I know also have are covered entities because they cite for clinical purposes. These are just some things to keep in mind. That we are changing the due to and changing it to because of, and this is because of the causal connection. So this is particularly important for instances where there might be like a natural disaster or something like that. There needs to be this causation so that an actor is actually showing that uncontrollable event is what caused the problem, and not sort of saying there was an uncontrollable event and over here unrelated, we just didn't want to respond to this request for this patient's data, or, you know, I know the public health faces these challenges sometimes yourselves, like they didn't want to report because of X thing. So those are the types of things to keep in mind, is that's why that we're making this particular change, is again, just to clarify that there has to be a causal connection for any uncontrollable event for the particular actor to use that as the reason that they would not share information. Next slide. So this is another one that is a little, all of these are a little wonky. I do apologize. I'm hoping that I'm coming across at least enough that it's making some sense, but keeping in mind that there is a lot of the information about information blocking for public health. What I'm most wanting to understand is that we're trying to clarify things. These are the pieces that we're trying to clarify, and you can take another look at this slide deck when we send it out to give you a little bit more information. But from a public health point of view, the important things for you all to be aware of are, again, to just remember to check through different lines of service and try and understand if there's any way that you might be considered an actor, whether it's because you are doing some sort of clinical services that relate and what that looks like. And then are there any ways that you might be acting in the role of a health information exchange or network? And there's some clear definitions on that I'll make sure to put into the chat when we get to the Q&A section. The other thing for public health that's really important to keep in mind is that you are a requester of information in a lot of cases. And some of those cases might be instances where public health agency has had their information blocked. It's not going to apply in all cases because it's all going to depend on what the information was and whether it's compliant with HIPAA requirements for minimum necessary and so forth. But if you are facing challenges with getting information, the other reason that it's important for you at least to have a little bit of dangerous knowledge about information blocking is because you should be getting the information that you're requesting under your permitted purposes and under any permitted request that you have. And if that's not happening, you could yourself be able to file a complaint and bring that to our attention and raise that with OIG as a potential issue that should be addressed or investigated if there's actually an action that is inappropriate and they shouldn't be blocking that particular information. So that's why we're putting this together for you. But again, I do apologize. I know that this is a little wonky. So hopefully you get enough meat to be knowledgeable and dangerous enough to know your stuff if you're faced with these types of circumstances. So the third party modification condition is under infeasibility. And this is one that is just something, again, for you all to be aware of because this is a continuous sort of evolving process. We're hoping that this gets better and better. But this is instances where in order to get the data, the actor would actually have to get a third-party entity to make the data usable. There are instances we might consider where things like a device that has the data in a specific format that the device has, and the user, the provider actor or the agency actor or whoever it is, the clinical research actor, if they're clinical and it's sharing this information, may only get a report out. They may not have that raw data. And so that's an example where this might come into play, that they aren't actually capable of getting it because the third party is actually needs to modify it in some way in order for it to be accessible. And so there are some further clarification around that, and we do seek comments on it. Again, it's a proposal, but hopefully that will help to set those parameters a little more clearly as well. Next slide. The other thing that we have done is a modification to the content and manner exception, specifically the manner exception. This is where for those who aren't familiar with it, this is where we set some bumpers, some due diligence guidelines for how to approach a request. So if you get a request, first things first, you should be responding, if you're an actor, if it's possible to respond in the format requested, that's what you do. So that's always sort of the gold standard, is in the format requested. But then from there, if you can't do the format requested, we didn't want it to be just an automatic, yes, no, or automatic get in trouble, or an automatic, it's infeasible. There's some parameters to help give guidelines. So it's not having to boil the ocean. It's thinking about, okay, well, can I use certified technology to do it? Can I use a specific standard to do it? Can I use a machine readable format to do it? And that sort of punch list helps to provide some guidelines and parameters around how you respond to a request when you can't do the available method. But it also applies for the requester when they're looking at, well, they can't do the method that I've said. What other method can we do? How can we work through this? So I think what we've tried to do is propose a reasonable amount of steps to say that due diligence needs to meet some baselines. So you sort of need to offer the options that are there, and that there should be at least a reasonable amount of alternative manners that have been considered. And then we've also gone through and said, well, what we should also make sure is happening is that it's not discriminatory. So in other words, you can't make arbitrary decisions or business-based decisions that would be discriminatory in some way about providing it to one entity in that format and then refusing another entity and trying to force them into a different format. Because there is some flexibility for the formats. Once you can't agree on the original one, there's some flexibility in working through that. So we talk about if you currently provide it or it is the same as currently provided, if there are a substantial number of provisions that are made in the same format or in similar situated entities have gotten the same format, that you wouldn't be able to punt on that still needs to be offered. And we think this provides better consistency a little bit more clarity and an amount of reasonableness so that it isn't a full laundry list, but it does still scope that there shouldn't be arbitrary decisions being made in that process. Next slide. So the other thing that we have done, and this is another good one for you all to just be aware of, is under the manner exception, we have included in a condition that specifically talks about TEFCA. So in other words, if there is TEFCA participation on both ends of the potential exchange, that this essentially creates a space where that use of that network and use of the TEFCA technical framework and the QHIN network structure would sort of preempt the rest of the manner requirements, and that could be the default mechanism by which you're approaching that particular exchange. There's a little bit more detail to it than that, but it's intended to ensure that people who have already gone through the process of engaging with the TEFCA participation requirements, which include, there is agreement to certain levels of trust and certain levels of technical capabilities and certainly certain levels of like first stage, this is the technical capability that we've all agreed to, that you don't have to redo that process, and essentially you can rely on that as your sort of default manner for which you would respond to a request. Next slide. So that is the sort of crux of the information blocking pieces. And again, I realize those are all weird little wonky text changes, and hopefully they didn't go completely over your heads and they give you at least some context of the types of changes we're trying to make. We're trying to actually clarify some things that might have been confusing or might have been inadvertently disincentivizing positive behavior. We don't want to disincentivize information sharing or technology sharing or innovative uses of tech by having information blocking requirements that make it seem like those might be too risky. So that's particularly what we've tried to address there. So the last thing that I'm going to highlight specifically, and then I think we're going to talk through how to get engaged and save some time for questions, because I think we go until 4:30 if I'm correct about that. I can't see the chat, so I'm assuming that I have a note somewhere that says that. But there is a specific request for information that we want your input on. We have done an extensive amount of research over several years looking at lab data interoperability in lots of different sort of points of view and perspectives leading into that, both from a public health point of view and reporting, from a COVID point of view, and the sort of broad sweeping issues both related to public health and targeting, and how you're connecting lab data with actual rates of infection and concern, and thinking through some of the areas of breakdowns that have happened because of challenges with lab data interoperability in lots of these different types of scenarios. There's some very obvious things that come to mind, again, with COVID, with the ability to aggregate lab data with demographic data so that you can target populations that are at higher risk and that may be under-resourced and need to have some specific attention paid to how access to care is being provided in those areas. So this is one of the challenges that we are interested in digging in more. So we have specifically asked some questions that we think that your input will be of particular help in us figuring out what we could be doing further, what we could be looking at further. Specifically, we asked about which implementation guides or other standards we should consider adopting in criteria for health IT transmittal and receipt of laboratory orders, lab test results, and directory of services specifically. Again, if there's other things beyond that scope, please let us know. Please comment on those. We are asking questions specifically thinking about developers of laboratory information systems. And this is actually a really important point. I put this in the chat in relation to something else, but we certify health IT at ONC. There's a historic understanding that ONC certifies EHRs, and that is where it started, but it has expanded beyond that, in part because of the needs of the industry, but also because our statute actually has us, we're required to look beyond what you might consider as a traditional EHR. So one of the pieces that we're trying to understand is what parts of the scope of the health IT systems should we be looking at supports for? And we've had historical things where we've looked at, for example, quality measures and what data services vendors and QCDRs and what do those quality data entities need, and we actually have criteria that support that type of thing. So some of these questions are about laboratory information systems. or diagnostic systems that maybe haven't previously been certified, but is there a need to provide those types of support for entities using those systems to ensure that they are meeting standards or are capable of doing certain types of exchange? Because we can look at that type of thing within our program and see if we should be expanding the supports that we're providing to different parts of the health IT community. And then we are also specifically asking if there are other steps that ONC and HHS should consider collaboratively or individually under our various authorities to help advance laboratory interoperability and see how we can make things better on sort of all parts of this, from the lab to the public health to the care provision to thinking about population health management, like all of the different pieces. What can we be doing together to try and help ensure that lab data interoperability is moving forward in a viable and effective manner? So that is, I think my last slide for R5. Let's see. I guessed wrong.
I think so. I got it
right. All right. It's a lot of talking. So Jeff, did you want to take this part and then we'll go into questions?
Yeah, sure. Next slide, please. Okay, so there are some other requests for information. Beth mentioned the lab data interoperability, but we're also interested in pharmacy interoperability functionality, as well as real-time, especially in the context of real-time prescription benefits capabilities. And then we do have a number of RFIs on FHIR standards, such as subscriptions, CDS hooks, FHIR standards for scheduling, and then smart health links. Okay, so yeah, sorry, go ahead, next slide. This is how you can get in touch with us. This is our mailing address. Not really, you have to go through a couple steps here, but if you want to give us comments, we've got a bunch of comments here in the chat, which is great. But in order to consider those comments, those need to go through the Federal Register or through regulations.gov. And we do have a public comment template that's available on the ONC website, which you're free to use and submit. If you go to the next slide. There are also some fact sheets. I happen to know that healthit.gov/NPRM also works, as well as healthit.gov/proposed rule. And this is where you can find previous webinars, you can find slides. I think you'll be able to find this presentation and slides perhaps. We also have a number of fact sheets, some of which are still rolling out. And you can find the measure specifications that I mentioned for the insights condition. So this is all the latest and greatest, and it's being updated constantly. So check back often. Okay, next slide, please. We are most of the way through a task force that was established as part of the HTI. There are, I think, maybe a small number of meetings, but those are open to the public. If you're really interested in this stuff, and if you have comments that you want the HTI task force to consider as they develop their own recommendations, you should check that link out, and you should plan on attending those. They meet, I think, several times a week, and I know we've got some of those HTI task force members participating in this call as well. Next slide, please. It looks like those dates have all passed. So next slide.
Yeah, sorry about that. We'll have to update.
Yeah, but if you're wondering what happened on those webinars, don't worry. You can find those at the healthit.gov/NPRM. And that is
the
that's
recordings
it.
are all available.
Yep. Okay, so I know we've got.
Great. Thank you, guys. Let you go, Jeff, and I can stick around and take questions.
No, it's all good. It's all good.
Oh, okay.
I can stick around now.
Okay, great.
Great. Thank you guys so much. We really appreciate you taking the time to walk us through this very comprehensive rule, and especially in highlighting some of the particular components that would be pertinent to public health. So with that, we're gonna start just kind of going through some specific questions, and I know Beth and Jeff, you both answered some questions in the chat, so please, folks, check those out. In the meantime, I'll start off one from Melanie, and I think, Jeff, this is talking to you. So what does this new rule say about the requirements around when an EHR must trigger the EICR? So triggering timing is very crucial in regards to EICRs, particularly needing it more real time than, say, like 5 or so hours later.
Right. Yeah, I think good comment and good question. We don't have anything specific to say about that in the regulation text itself. However, I do know that there are both trigger timing and trigger logic built into the ERSD profile. And we are requiring the ERSD profile for both CDA and FHIR approaches to case reporting. So the answer to that question, which I do not have in front of me, likely lies within the ERSD profile. So Melanie, I would invite you to look at the ERSD profile and also, kind of come back. I'll put my email in the chat so you've got it. Come back. Feel free to ask follow-up questions after you look at the standard. That's what we're relying on is the standard. So if there's timing logic that needs to be there, let us know. And if you look at it and you don't see it, we can have our SMEs and our team also take a look at this question. Then we can just go from there.
Great. Thanks so much, Jeff. And while we have you, maybe you could also talk, Ronald posed a question about how do you envision testing one of the programs that's been stabilized?
Yeah, so again, another good question. We don't speak to testing in the proposed rule. And in fact, we generally do not speak to testing. We think of testing as one, but not the exclusive way to ensure conformance. So there are multiple ways of ensuring conformance. Attestation is one way. So basically, you legally put the developer on the line to attest affirmatively that their technology adheres to the requirements. That's what we've been doing with electronic case reporting historically. I can't really speak to exactly what we will do conformance-wise and how we want to ensure conformance, or what kind of methods we will use to ensure conformance, because again, there's multiple ways you could do this. We don't employ code review, but that's one way to do it. Some of our criteria are visual demonstrations during testing. So we don't have a test validator per se, but the testing lab makes the developer do a visual demonstration of the technology doing what it's supposed to do. So there are various ways we can think about this. Obviously, if you've got thoughts on how testing ought to be done, that is something that we'd welcome, and that's something we could have via email. That doesn't need to go through the Federal Register, because again, we didn't propose anything related to testing in the NPRM.
Great, thank you, Jeff. And thanks again, and just referring folks to Jeff's email that is in the chat. Beth, I'm hoping you could answer a couple of questions around info blocking. I know you kind of talked a little bit about like public health and how it's required and not required in information blocking. So I just want to make sure that you kind of clarify for the group about that.
Sure, and I think there's a couple questions in the chat that I just popped into the chat, a thing that I'm going to talk through a little bit. It's sort of a baseline understanding of what information blocking is and isn't, that I think are actually addressed by a sort of foundational principle of what it is. So information blocking, in the phrase that I popped into the chat, you can see where it says, except as required by law, or as specified in an information blocking exception. But I'm going to start with the except as required by law, and then we're actually going to work backwards in the sentence to some of these other things. So if there is a law that is defining what can or cannot be shared, And that means HIPAA, but it also means state laws for lots of different purposes. It means things like Part 2. It means things like HIV status, depending on the state law. It means things like behavioral health or pediatric data, depending on the state law. And it could also mean public health, depending on what's defined for your purposes by the public health agency. So all of those things are included in that construct of except as required by law. If a law prohibits it, it's not even in the ballpark of information blocking because the law prohibits it. Now, keep in mind that if the law prohibits it, using, again, the cause by and due to construct here, if the law prohibits it, you can't use a blanket statement to say anything like it is also not going. So for instance, one of the cases that comes up a lot is Part 2. Part 2 requires the non-disclosure of certain specific information from a Part 2 visit. And a Part 2 visit or Part 2 information is a Part 2 encounter. It's a specific encounter with a healthcare provider. The same healthcare provider may be a Part 2 provider and a not Part 2 provider and may have similar information, but it really only applies to that Part 2 information. So information blocking is saying, except as required by law, the Part 2 encounter, it's applicable. It can't be redisclosed. It can't be disclosed. The same healthcare provider cannot also just block all of the information they might have about anything relating to opioids for the patient if it has nothing to do with that encounter. They have to explicitly, specifically address that and ensure they're complying with the patient's wishes or consent wishes or what other laws might apply. So all of those laws come first. That's just a really important thing to keep in mind. And that does include like the public health authorities, right? The public health authorities and your interface of your authorities with HIPAA, so things like minimum necessary. So moving back from there, the other thing that you need to keep in mind from a public health point of view, both as a receiver of data, so someone who's making a request, and as the actor, is what are we even talking about? What data are we talking about? And we're talking about EHI. And EHI as a definition is very specifically tied to the HIPAA definition of EPHI, so electronic protected health information. So if it's not electronic, it's not in the game. If it's not EPHI, which again, remember the definition of EPHI is tied to information in the designated record set. So that's just something to keep in mind that, you know, aggregated de-identified data might not be EHI. You have to double check on that and make sure that your statuses of what you think that is for HIPAA purposes are clear, because that's going to carry through. It's aligned to HIPAA. So if it's not EHI in the first place, it's also not in question. So it's just a really important thing to keep in mind when you're thinking about what is and isn't EHI, and what is or isn't a permissible exchange. That is, there is no other law that's saying it has to be done X way, it has to be shared X way, or it has to be restricted. And that's when it starts to come into, okay, so now we know that this is an exchange that is using EHI, and there's no law that says it shouldn't, and there's no law that says it only has to be a certain way or it only has to be a certain constraints. From there, what can you either require from an asking point of view, or what can you be required to share? And that's where you need to take a look at your services and your program requirements. Your program requirements don't automatically get, like, they don't get derailed by information blocking. Our authority doesn't oversee what your program requirements might establish. But the other thing to keep in mind is that it isn't a direct one-to-one. I think there was a question in the chat about, would a program requirement trump someone who wants to send you something in a different format? And the answer to that is we don't know. It might not, because it's going to be case by case. If you're asking for something that is infeasible for the respondent to give to you as the requirement, then it's going to come into question of whether that they can use that exception or not for infeasibility. So these are just things to keep in mind as you're thinking about things. Generally speaking, if you continue to look at what you do with HIPAA and what you think about with minimum necessary, continue to look at things like the standards that are used and how those computable standards can facilitate getting the data you need in the formats you need. And keeping those things in mind at the forefront will help to make sure that the weird cases, those edge cases, are a little bit easier to manage because you'll be addressing the overall scope. And again, I'm not trying to say it may or may not to be difficult. It's just that information blocking is quite literally a case-by-case basis. So we can't actually say this particular use case or this particular instance, you've asked for it in this format, they want to do that format, you've gone through a process with content and manner, and is it information blocking if they don't do that way? Can't tell unless that's been the individual circumstances actually have to go through an investigation to make that determination. And that's because the way the statute is designed, it is a case-by-case basis. So we can't actually go to that level. So I hope that at least helps with some context. And I do, again, sorry that I sometimes have to say I can't answer, but for the nitty-gritty of a particular use case, I actually can't answer because it would be case-by-case.
Thanks, Beth. I know that that's super complicated, and I'm sure we'll probably have more, stuff in the future and tools and resources that we can direct you guys all to. One around the manner exception clarification. This is another public health authority question. Would public health be able to say, we will only accept XYZ and require senders to use those formats under the manner exception?
Sorry, can you repeat? I missed the first part and then I heard XYZ.
Yeah.
Sorry about that.
Yeah. No worries. It's been Crystal and it's in the chat, and she asked like the manner exception clarification. This is another public health authority question. Would public health be able to say, we only accept XYZ, unquote, and require senders to use those formats under the manner exception?
Got it. Okay, I see what you mean. Thank you. I was trying to find it and then I lost track. Okay, so this is where I was saying the piece about, so under public health authority, none of your authorities are changed by this. So your authority to define your standards that you're requiring people to send and the information that you're requiring people to send is all still applicable. The thing to keep in mind is that from an information blocking point of view, it isn't about your authority, it's about the capability and the feasibility of the actor who is being requested to respond in the manner requested. So for there, it's sort of looking at it from that point of view of, can they respond in the manner requested? And if they can't, is there the possibility of an alternative? And if there isn't, then there's the infeasibility. So it's again one of these things that it isn't a clear cut that you can say, if you don't respond, if you don't report in this particular fashion, then it's information blocking. That is not something that we can say. It would have to be, again, a case-by-case basis. Now, that doesn't change that you can set the requirements for your program, under your authorities, for what you would require the reporting to be. It's simply a matter of that it doesn't necessarily equal that it constitutes information blocking if an entity isn't able to report in that mechanism. I hope that helps provide at least some clarity on where the line kind of is.
Great, thank you, Beth. Really appreciate it. I think we have time for just one more question. I'm going to circle back to Jeff. Jeff, I know that you mentioned that there is a new date as it relates to folks being able to implement F5. Can you just clarify that? I think that some folks might have a different date in mind. So just want to make sure we have that clear.
Yeah, sure. So The way that we constructed the update to F5 is essentially that a developer may certify to using a standards-based approach, whether that's CDA or FHIR, as soon as the rule is finalized. If we finalize as proposed, a developer could certify using standards. I think it's 60 days after publication is when the rule is generally considered effective. But so that's one option. The other is, essentially a developer would have until the end of 2024 to update to standards. So that's slightly different construct than some of our other certification criteria. The big picture, though, is that developers must update their technology to a standardized approach by the end of 2024. So I think in the slides there was December 31st, 2024 and January 1st, 2025. So essentially, those are one and the same, but they would have until up to and until December 31st, 2024 to update their technology and provide that to their customers.
Great. Thank you so much, Jeff. So we're right at time. So I just want to thank you all so much for participating in this really interactive session, and want to thank Beth and Jeff for your thorough review of the rule, as well as taking the time to answer these questions thoughtfully. And we really appreciate, again, this webinar, as well as the slide deck and associated chat, will be posted on healthid.gov, and we will be sending out something shortly connecting everyone to that link. So thank you all again so much. Really appreciate it. Have a great rest of your day.